Thank you for joining us today as the American College of Surgeons continues to recognize Suicide Awareness Month, and this week, on Thursday, September 17th, recognizes Physician Suicide Awareness Day. I'm Dr. Wendy Green, and I am a professor of surgery at Emory University School of Medicine, the director of acute and critical care surgery, and the site director for Acute Care Surgery Fellowship of Emory University. I'm also the Emory co-chair for the African American Women's Collaborative, as well as the Inclusion, Diversity, Equity, and Anti-Discrimination Group for Critical Care. I'm also a fellow of the American College of Surgeons. I'm privileged to be joined by Dr. Charles Balch and Dr. Amanda Kingston. Dr. Balch is a professor of surgery in the Department of Surgical Oncology, researcher at the University of Texas MD Anderson Cancer Center, and a fellow of the American College of Surgeons. Dr. Balch is a leading clinical and academic surgical oncologist, the founding editor-in-chief of the Annals of Surgical Oncology, and the editor-in-chief for Patient Resource Cancer Guides. In addition, he has held several executive leadership positions across healthcare institutions, societies, and additional professional organizations. Dr. Balch earned his MD from Columbia College of Physicians and Surgeons. He completed surgical residencies at Duke University Medical Center and the University of Alabama, Birmingham, and a fellowship with the Scripps Clinic. In addition to his significant research, tumor immunology and human T lymphocyte differentiation, Dr. Balch has also researched surgeon wellness, burnout, suicide, distress, and the relationship between career success and personal wellness. Dr. Amanda Kingston is an assistant professor of clinical psychiatry and the Forensic Psychiatry Fellowship Training Director at the University of Missouri, Columbia. She is also the current medical director for the Fulton State Hospital. Dr. Kingston completed her medical training and residency at University of Missouri. She completed a forensic psychiatry fellowship at Yale University Health Services and is double boarded by the American Board of Psychiatry and Neurology and the American Board of Psychiatry, Neurology, Forensics. Dr. Kingston also maintains a clinical practice with a focus on young professionals, early career, and families struggling with ADHD, anxiety, depression, postpartum binge eating, and/or substance abuse. Dr. Kingston has presented on and written about physician suicide as a silent epidemic, highlighting the longstanding issues of physicians struggling with mental health issues. Today, we would like to thank both Drs. Balch and Kingston for being with us. For our discussion today focuses on physician suicide awareness and prevention, and how to shift the culture to destigmatizing mental health and keeping us safe and seeking help. We'd like to ask a few questions. We know that suicide is a disproportionate cause of death for US physicians, and a few seek psychiatric or psychologic help, which in turn may have implications for patients too. What are some of the most prevalent risk factors you see in your research that could lead to death by suicide for physicians and surgeons?
So I've had personal experience with some faculty members and other people who have suicide ideation, and actually 2 instances of people I've published with who have committed suicide with what I thought was the peak of their career. So this is something that can happen. It's the extreme consequence of burnout or depression. And I think is more prevalent in the so-called be perfect person that somehow feels if they have had a failure, such as a major medical error, they haven't gotten promoted, they've had family issues such as divorce or health tragedies, that they don't see any other escape except taking their own life. And there's always a journey before this for people that if those around them recognize the symptoms of burnout and depression and can help point them to getting assistance before they get to that extreme, then physicians and their patients will all be better served.
I have also had some unfortunately situations where I've had colleagues who've struggled with mental health issues, and I've lost a colleague to suicide. In my research and writing, I found similar risk factors to what Dr. Balk mentioned. There's also been some data to show that those who are described as driven and competitive and graduated from highly prestigious schools are at a little bit higher risk for suicide within medicine. And any underlying medical illness or psychiatric illness is often perceived as a personal flaw or failure on the physician's part and can also increase their risk. There is a slightly higher risk for women physicians than men, and certainly than women in the general population. And of course, history of suicide attempts, family history of suicide attempts, not having social support, kind of the typical risk factors we think of for all individuals still apply to doctors. And we have identified two particular areas in a physician's career that are the highest risk, and that's the early career time, that first 7 years out of medical school and in practice, and after retirement. And after retirement, it's thought to be related to this loss of identity. We as physicians are always physicians, not just when we're at work. We don't turn it off when we go home, most of us. And losing that major part of our identity with retirement has increased risk. And then that first 7 years, as many of us know, is a very stressful time. And like Dr. Balk mentioned, might not get a promotion you expected, might not get a job you expected. And so those can be really times for physicians.
Dr. Balk and Dr. Kingston, so you were talking about the risk factors, and some of them were so broad that they put every physician could be categorized or at risk. If we were to want to look at our colleague and be an advocate for our colleagues in the workplace, what are some things that may be more specific besides the promotion times and change of career times that we should look out for? Are there things that we might start looking for as far as morbidity, mortality, more missteps? What can we look out for that we might be able to use on a day-to-day basis?
Well, the first thing I would say is those surgeons who think they are not at risk may actually be at the greatest risk. And what I mean by that is we have to practice self-awareness, including accepting the fact that we are not perfect, even though we strive to be. And I think it's very important for each of us have mentors, both personal mentors and professional mentors, who can give us honest feedback the way the world really is and not just the way we want it to be. And I think those things are very important. I also think that there's a corporate responsibility for leaders to be looking out for their faculty, not just for their role, but who they are as a person. What do they bring to work that may be stressful that you might not know about unless you ask the question about how you're feeling? And then the other is our individual responsibilities for practicing personal wellness proactively. So I'll stop there and let Dr. Kingston add her part to this as well. But I think there are two parts. One is prevention, and the other is those individuals who do get into problems with burnout or depression to intercept that pathway, a downhill spiral, so that they don't end up with the consequences of alcoholism, drug addiction, or suicide. Those are the extreme consequences that we really want to avoid, but do happen tragically.
And you mentioned something that I think is also worth pointing out is that just by being a physician, your risk of dying by suicide is approximately 3 times that of the general population. So every physician is at a higher risk than the general population, just inherently by being a physician. And some of the personality characteristics that medicine selects for, as well as the intense pressures many physicians face within their work and home life. But the things to look out for in your colleagues really are big changes. That's always a time to be having kind of an extra eye out So if they have a change in their relationship, they get divorced, or their spouse passes away, or they lose a close family member, their job changes, they move, they have a big event at work, like they lose a patient or have receive a malpractice lawsuit, or any of those big incidents, is a time to be extra aware. And then any colleague that seems to be acting differently than you're used to. So whether they're acting more anxious, depressed, they seem intoxicated, or are struggling with duties they didn't previously struggle with. Those are always times you want to check in, get an extra idea of how they're doing in terms of burnout, depression.
No, and the thing I would add is if all of us understand and look out for these changes in symptoms among our colleagues, especially those in a supervisory role, if they know that one of their individuals is going through a major life change, a death, disease, divorce, one of the things we've written about has been malpractice. And that can be very tough on the perfect doctor, because the consequences of a malpractice is going to be accusing you of being a failure. And if those are going on among our staff, we need to be sure that we're surrounding and supporting them for any of these major changes. And as Dr. Kingston said, we could all recognize big changes in the personality of our colleagues. And if we see that, you need to tell somebody who is either a supervisor or a mentor, and be prepared to send them to a confidential place where they can get assessment and help. Because one of the messages is all of the people that I've had experience who have gone on to suicide, people saw a change in them and tragically let them go off the cliff without any intervention. And so I think we all have a responsibility for this awareness, not only for ourselves, but for our colleagues around them. And the bottom line is caring for them, knowing what's going on in their life, knowing when they've had big stressors, and then supporting them so they can get through it.
Absolutely. So, there's some great points that you brought out about the many factors that we can look out for. And have you known any organizations that have set up reflexively, especially if someone got a lawsuit, something that is a big trigger, where they sent out some information, a wellness check to the individual so that they could assess themselves, so they wouldn't get lost in the fray? Have you heard of anybody doing that as an automatic solution?
So I'm not familiar with any national organizations, that have that type of setup. There are some national initiatives that are present in some facilities. One is called ASAP and one is called 4U. And those are both kind of critical incident debriefing programs that include some screening tools and triggers for referral to things like EAP or community resources, depending on the facility and what they have available. But those require the hospital to kind of opt in and do training and have those in place within their facility as a part of the national initiative.
Thank you so much. So as we look at the many factors that detract physicians from seeking care, in your opinion, what shifts in the culture of medicine need to occur to reduce barriers, challenges to asking for help?
Well, step one is at the individual level, and that every surgeon ought to understand the issues of personal wellness. It's interesting, in the surveys we did with the College of Surgeons, it proved what we all know, is that we as surgeons don't practice the personal wellness and the health issues we tell our patients to. We don't go to the doctors as often. We don't get the prevention checks. We don't practice wellness because we're too busy saving lives and make these personal sacrifices. So I think one of the solutions is have mentors that we have to seek and meet with them regularly for an honest evaluation and feedback. Somebody who is not in your reporting relationship, that you could have confidential discussions and get feedback that you might not otherwise get. So I think that's one of the things is prevention and practicing personal wellness, because it's acceptable in the culture of our institution because our leaders have made it acceptable. And then the other is for everybody to understand, if we get into trouble, that there are outlets for getting confidential assessments, and then if necessary to get help as you need to before it gets spiraling into a downhill course.
Do you see that as being something that they put on the annual, they have annual information that you should learn about the organization? Maybe the faculty assistance programs, the anonymous self-reporting tools need to be a part of that, just like any kind of medical records or billing updates that we get.
Well, one of the problems that Dr. Kingston can address this is I think we still have the stigma of mental illness, both in terms of asking questions that people are afraid to answer honestly, and worries about their licensure if they've had some mental illness. And somehow we need to decrease the stigma associated with this if we're going to allow people to be more open.
Absolutely, I agree with that. There has to be a pretty huge culture shift in medicine, and I don't just mean among doctors, but among healthcare corporations, medical boards, insurance companies, and that's going to require things like rewording questions on hospital privileging packets and board applications for licensure, focusing more on functional impairments rather than diagnosis. So some states have started doing this and changing their licensure questions to, have you ever had a medical or mental health issue that impairs your ability to practice medicine? And that's a step in the right direction from many boards who still just say, have you ever been diagnosed with a mental health issue? And then if you say yes, it can trigger further exploration or inquiry, which makes physicians probably rightfully nervous. And malpractice insurance applications contain these types of questions. And I really think that starting early, even in medical school, it's harder to change bad habits than to start with good ones. And so we need to teach our medical students as they go through school and residency that their own personal wellness is important and that they have ways to keep themselves healthy, and they don't need to get so far down the road that they're already in a clinically significant episode of depression before they reach out and get help, and trying to create that culture of being personally accountable for your own wellness early in their careers.
Dr. Kingston and Dr. Green make some very important points. Is medical students and residents have a high risk of burnout. We all think this is the midlife crisis, but it really starts at an earlier age. And my friend and colleague, Tate Chatterfeld, who's really one of the nation's experts on this, has pointed out that the root cause of this for many people is the so-called delayed gratification. We make personal sacrifices to get into medical school, then get into the best residency. And even then when we get our first job, it becomes self-inflicted because we want to have a good practice, we want to be promoted. And the more we continue putting off our personal needs and not having outlets, hobbies, things outside of the workplace, the greater the risk is at some point in time that delayed gratification comes back to affect you in the form of burnout or depression and the consequences of that. So at MD Anderson and the places that I've worked, we actually have an hour or more talk to the trainees about understanding their risk for burnout and the symptoms of burnout, so that everybody can hold their colleagues accountable if they see that happening within them. Using drugs or alcohol, for example, to get through a rough spot, which is fine on an occasional basis, but when people depend upon that, then they get into problems with addiction that can really come back to haunt them, including suicide.
Dr. Kingston, when you were talking about the impaired function questions that are on licensure as well as malpractice applications, is the wording such that people who are controlled because they're on medications are because they're controlling their mental condition because of they're on medications? Is that included in this, or is it really those who aren't on medications and things aren't controlled?
So it really depends on the state, the company, the hospital organization. Traditionally, those applications all contain wording of if you had ever been diagnosed with any mental health issue, you had to say yes, and they then had further questions. Many states have taken a step forward and changed it to, do you have symptoms and do they impair your ability to practice? So that if you are in treatment, you are getting therapy, taking medication, that you then can say no on that question, that it doesn't impair your ability to practice, and it just ends there without further kind of monitoring or inquiry.
That seems helpful to be as a big push so that people will at least get help where they need it, and if medications are needed, that they wouldn't feel penalized as a result for seeking help. Thank you for clarifying that. So thank you both for sharing your thoughts on the shifts in the culture of medicine to support and initiate these shifts. What do you think are some key initiatives and or programs hospitals, training programs could consider implementing to create a prevention system? Dr. Ball?
Well, the first is every institution from the top down, including the surgery chair, the division chiefs, need to understand there is a corporate responsibility for their staff and their physicians for personal wellness, and having open programs so that the culture is one that if people are having issues, it's not a stigma, that they can seek help. So it starts at the corporate level. John Noseworthy at the Mayo Clinic has written an excellent article I would commend to everybody about our corporate and moral and financial obligation to our faculty and staff to practice personal wellness. And then at the individual level, to understand and really practice personal wellness. For example, taking vacations, having hobbies, getting sufficient rest, not just to rest up for work the next day, but having outlets that are relaxing. It's kind of amazing to me that one of the things we found in our survey is surgeons don't take their allotted vacation time because they're too busy. And that's a time that they should be resting up or spending time with their family. They don't have hobbies. They don't go to the gym and practice physical fitness. Those are very common things that we say, we should all do this, but we get into this mindset that we are too important and too busy to do those things, and we put off those personal needs that I think is the root cause of this downhill course that we call prevention, depression, and ultimately suicide as the final escape.
Along those same lines, I think it really does require a high level support and interest in the physician's well-being, including changing the cultures within hospital systems, having anonymous sources for evaluation and treatment, encouraging vacation by providing coverage for them when they need it, making those easy to do, having critical incident debriefings. We all, as physicians, have bad things happen in our practices. It's inevitable, no matter what specialty you are in, but certainly within surgery, you will have bad outcomes at times. And having the Lent groups to debrief those, or using one of the critical incident debriefing initiatives to provide that extra support and to talk through the incident in a non-judgmental way, and having referral sources if further issues are identified. Also doing regular screening for burnout, for depression, for suicide, and having those trigger resources based on the physician's answers to the questions. So it's not enough to just get the data. You need to also have resources for those who you identify as being burned out or identify as having depression, and certainly those that identify having suicidal thoughts. And the other thing that I think is really important and talks back to what we were saying with the board licensure is to really have a culture of encouraging treatment rather than punishing it. So we don't want to charge our doctors with vacation time every time they need to go see a therapist or a physician for their treatment. We need to make sure that we're providing time for them to do those things, the space to do those, not requiring additional reporting and inquiries when they're getting the treatment that their doctor recommends, they're adhering to it and doing well within it, rather than trying to set up this somewhat punitive system of forcing them to get documentation at every visit about if they're adhering to treatment or not, forcing multiple drug screens, or mandating EAP or fitness for duty evaluations when there hasn't been a serious issue at work and they are just personally identifying that they're struggling, and allowing them the space to get that treatment and supporting that.
Yeah, and Dr. Green, I think one other point for our listening audience here is that each of us at a different point in our career have different stressors and risk factors that we face that's inherent to our age and where we are in our career and our practice setting. And both the supervisors and the individuals need to know where they are on that risk for burnout and depression, and ultimately, if untreated, we go into alcoholism, drug addiction, or suicide. And so we've published work to show that certain specialties, both in internal medicine and surgery, acute care medicine is at the highest list, and pediatrics and pediatric surgery is at the lower list. And you can see where you are during your specialty, hours of work, night call, whether you're married to a healthcare worker. We've actually published on surgeon marriages or partners, and they are at very high risk, both especially when they have children of young and teenage life and somebody's taking care of the kids. And it's those kind of circumstances, if we see somebody is inherently at a risk, that we're flexible about being proactive with them, being flexible with their schedule. You know, if a woman has 3 kids and has an operative caseload one day and the housekeeper calls in sick, what are you going to do? Somebody has to help, because that's a big stressor in a work-home conflict that on a continued basis can really lead to burnout and depression unless the system is flexible enough to recognize it and help people through it.
As you brought up so many rich topics today on the discussion of physician suicide, one thing that we need to posit into the listeners' thinking is about, besides the suicide, we also need to be aware and mindful of domestic violence, and looking out for those triggers that may be going on as another stressor, that people may be in abusive relationships that have led to some physicians being killed by their partners or others. And this is another part of that, being aware of your community and your colleagues, and having an eye out, not just for people's ability to work around you, but also for them to, you want them to be whole. So we want to thank you so much, Dr. Balch and Dr. Kingston, for sharing your knowledge and expertise with us during Suicide Awareness Month. We are grateful for all the work you both do to help us understand this silent epidemic and how to address it. Thank you so much.